Hello, everyone, and welcome to today's webinar hosted by the Oregon Office of Rural Health. I'm Rhonda First, the Rural Health Clinic Program Manager. Today's webinar is presented by Tressa Sacrey, and it is titled Critical Maintenance, Emergency Plan, Biennial Review, Civil Rights, and Personnel File Audits. Tressa Sacrey joined Health Services Associates in May of 2015 as a compliance analyst. Ms. Sacrey has a bachelor's degree in education and has completed courses in business applied technology. Her key areas of responsibility include creating policies, developing emergency plans, facilitating hazard training, researching CMS regulations, conducting on-site compliance mock surveys, and creating forms and tools to assist RHCs across the nation. So we would like to welcome Tressa. I would also like to cover a few housekeeping details. This webinar will be recorded. Eric Jordan will post the webinar and slides on the Office of Rural Health website within the next few days. Eric is our tech support during the webinar. If you have technology questions, please send him a message in the chat box. You are all currently muted and your video is off. Tressa will be happy to answer questions throughout the webinar. So just go ahead and enter those questions in the chat box and I will read the questions to her. At the end of the webinar, I will put a link to a survey in the chat box. Please take a minute to complete that survey. Well, without further ado, I would like to introduce Tressa, and also don't forget to complete those polling questions. Tressa, the floor is yours.
Thank you, Rhonda. I'm excited to join you today as we discuss critical maintenance for the RHC and how to maintain compliance really in these specific areas as you move through this year, especially this last year where there were so many unknowns. Allowing some time to discuss what elements need to be monitored as we continue through compliance and into survey. Whether you are already certified or you're seeking certification, whatever your story may be, I hope that you find this session informative and helpful. Our overall objectives today is to allow time where you are able to gain understanding of the required civil rights elements for the clinic, also to discover which documents might be reviewed during a personnel file audit during a survey, and then also to look at the operative guidelines and timelines for the emergency plan review. There have been some updates that have been provided over the last few months, specifically in September of 2020. There was an update from CMS regarding the testing requirements for an emergency preparedness plan. We'll cover some of those details as well. The first area I'd like to cover with you is civil rights. I will probably be offering tools and items throughout this presentation as well, and I'll make sure to get those to Rhonda Ann following this presentation to have available for you. As we dive into civil rights, the first item I'd like to cover is what signage you need to have within your facility to meet the requirements under the civil rights guidelines. And the first item we really need to have in place is the 1557 poster. And this is an allowance or a poster that outlines the top 50 languages for your state and gives your taglines or your non-discrimination statement to your patients in their given language, at least the top 15 for your state. That needs to be posted in your waiting room or in your lobby and available to the public. And then if you are part of a network, a hospital's network, and you are considered provider-based, a lot of times they handle civil rights for you. And this really isn't going to be something that's applicable to you, except for I do challenge you to go back and ensure that these updates have been made. The portal for compliance for the Office of Civil Rights has been updated within the last 2 years. And so just making sure that your current policies that you referred to, if that's the process you've chosen, is up to date and current. As you're applying for certification, if you have not gone through that process yet, part of that process is having to attest through the Assurance of Compliance portal that you are in compliance with the Office of Civil Rights guidelines. So there's a place where you go in and you are filling out an attestation that you meet all of the requirements listed within their site. And of course, you might also need to submit information as you go through that process. The acts that you are attesting to when you go into that portal are the ones listed here on the screen. And the reason the bottom number 6 is highlighted in red is because that is an update. Those were not part of the compliance portal previously. The portal was actually shut down for a little while through my colleague in the tailspin for a little bit while she was trying to get applications submitted for clinics we were assisting, because they were trying to update it and make sure that this was included in that process. And the main objective of each of these items is that you are familiar with the content and your policies address these, and you are in full compliance and you are not unknowingly committing discrimination against your patients. Do you have to be fully aware of all of these documents? No, there are great templates available on the Office of Civil Rights website that you can obtain and update and reflect your specific clinic. And then there are some policies and posters that you can obtain as well for the 1557 requirement. One of the policies you need to have in place, and again, there are templates on the Civil Rights website, is your non-discrimination policy. How do you handle your patients and how do you interact with your patients? And are you making sure that your language is current on the list of items that we cannot discriminate against? And then also listing out what services you have available for persons who do have disabilities or limited English, for example. And then disclose contact information for your designated coordinator, whoever handles your complaints and your grievances. You are supposed to disclose that person and their contact should be available to your patients. And then clarify how you disseminate your notice of non-discrimination. And you need to cover 3 areas: how you notify the public, how you notify the personnel, and how you notify your patients. And so typically what we see in this area defined in a policy is you notify the public through postings or through your online presence, such as social media or your website. And then for your patients, you have something posted in your lobby that defines your process, what's available for them as aids, and who to contact to obtain that assistance. And then for your personnel, you're disclosing the non-discrimination statement in your policy, and you're reviewing that at hire, so orientation, and then annually thereafter. Another policy that we need to ensure you have in place is how you handle admissions. What is your eligibility requirement, and have that defined in your policy. This becomes a legal backbone for your facility as well, and allows you to make sure all of your staff are trained across the board on how to handle civil rights with your patients. And then age restrictions. Majority of the time, this is not an issue for facilities. Where we might run into a struggle is, say you're pediatrics only, and so you don't see patients over the age of 18 or 21. You want to make sure that you clarify in your policy an age restriction statement that allows the surveyor to understand, or the public to understand, that the reason we do not see patients beyond this age group, and then you go into the statement that you are going to create. Typically what we see here is because our providers are specialists in pediatric services or something along those lines, where our services are only catered to this age demographic. It's not that you're discriminating against adults, you are just, your practice is designed for this age demographic. But when you put that statement into a policy, it allows full disclosure of why you've chosen the services you have and your overall practice. The statement that's on the screen is what we typically see for primary care, where you're serving all age demographics. And so I wanted to provide that for you. Then we have to describe our grievance process. And what is your procedure for a patient wanting to file a grievance? You need to outline your due process standards. And typically what we recommend is that you have a poster in your lobby that defines how you handle it at the clinic level, who's responsible, and provide their contact information. If it can't be dissolved at the clinic level, then we want to escalate it up to administration or your CEO. Sometimes the medical director or owner fill that role depending on the size of your facility. Sometimes it goes into office manager. Sometimes they have to fill that role. Whoever handles it at clinic level, and then who would handle it if it still remained unresolved. So you have those two contact information on this poster. And then the third item you need to include is your deeming entity. So if you are surveyed or certified through the state, you also need to include their contact information on that poster. If you have utilized an outside deeming entity, such as the compliance team or Quad ASF, their information would be required on that poster. So disclose who handles the grievances and then also their contact information. That should be a poster in your to the public in your waiting area, and it should also be in your policy manual. Then we need to have a policy listing how you handle patients who have limited English proficiency. Describe your procedure for oral and written communication with persons with LEP. Disclose staff who are qualified interpreters, and I want to emphasize the word qualified there. There are some categories that need to be met in order to be a qualified interpreter, and those are outlined directly on the site of the Office of Civil Rights. And so making sure that fluency is proven and before you list them as a qualified interpreter. And then the agency that your clinic has contracted with for interpretive services. There are many options out there. I don't want to sound like a commercial by any stretch of the imagination, but the main objective is that your patient should have access to interpretive service 24/7. And one way we have seen that successful for clinics is that they contract with an outside agency. A common one we see is Language Line Solutions, where you register with them. They give you a phone number and a PIN number, and that becomes something that's accessible, and you only have to pay if you actually utilize that service. Some insurance agencies, you're able to work with them to accommodate your patients with an interpretive service, and you can go down that route if it's available, but you at least have to show you have the capability of offering that for your patients. And then, of course, with civil rights, we always want to ensure that we are protecting PHI. And this needs to be disclosed even for patients who have disabilities or limited English. And so a child should not be used as an interpreter, even if they're related to that person. And these need to be defined in your policies. Again, there's great templates on the Office of Civil Rights website that you can go to, and they give you kind of a multiple choice option where you can just click and choose what items apply to your facility. Then we move into auxiliary aids, and we have to describe your procedure for assisting persons with speech, hearing, and visual impairments. Disclose which staff members are qualified for sign language, or again, that agency that can step in and assist in that role if needed. As we look at auxiliary aids, one other item I would want to address is making sure that you list out what aids are available for these patients. Do you have note takers? Do you have staff that could act in a reading capacity for patients if needed? Do you have any devices on hand that assist with hearing impaired? Maybe a speakerphone or a hearing aid compatible telephone set? Do you rely on your state relay information? Whatever tools or devices you have available that can assist your patients, list them out in this policy. Then we talk about accessibility, and that's one of the very first things that is reviewed when a surveyor shows up to your premises is, are you handicap accessible? Are patients able to access care at your facility? And so do you have the appropriate curb cuts? And if you have elevators in your facilities, do you have, if you have more than one floor in a facility, do you have elevators for access? You have level access to all rooms within your clinic, and especially patient care areas where they would need to have access. Do you have convenient parking that's labeled for your handicapped patients? And then listing out those services and aids that you have available for them. Here's a list of helpful links, and you can go in and I want to make sure that you are utilizing the correct link. And so .gov is your go-to source. You want to make sure that it's a reputable site that you're going to. And so that's why I wanted to provide these links for you. There is the Assurance of Compliance portal. Again, if you're working towards certification, that's one of the items that you have to complete and can show that you are in compliance with this piece. And then The update that came out in January of 2020 was regarding those conscious protections. Remember that red font that we discussed at the beginning of civil rights? That is what those really are relating to, is not discriminating against conscious objections or protections on your patients and your staff. And so I wanted to provide a link that allowed you to go in and search more on those updates that came out this year. Well, I guess last year at this point. And then also sample policies, because I talked about them a few times, I wanted to give you the link directly to that site so you can go in, access those policies if you don't already have civil rights policies in place, and make sure that your clinic is in compliance. Again, if you're part of an overall health network or a system where you have a civil rights coordinator or a compliance officer, or sometimes the person who handles this, ensure that you can confirm with them that your policies are up to date and meet all of the current standards listed at the Office of Civil Rights website. And then you have access to those policies if the surveyor were to ask for them. And again, the top 15 languages by your state. This link here lists those top 15 for your state and then allows you some access to be able to create your own poster if you don't have that already. You can also reach out to me, and Rondi, I'm going to ask that you write this down since I'm offering it. You can reach out to me. I believe I already have a poster created for the state of Oregon. I'm not sure how to pronounce that appropriately. I apologize. And I can get that to you if you would like. My email will be at the end of this presentation. So now we move into personnel files. And I always like to give a disclaimer that I try and make this as general as possible for all entity types. What I mean by that is some facilities, they have an HR department that handles this offsite. So the clinic really just refers to them and they handle everything for the facility. But you should still be aware of what they are looking for. What I mean by they is the surveyor, what the surveyor could be looking for so you can ensure your clinic doesn't get a deficiency. And then also other types of facilities, an independent, for example, would have everything on hand and they handle HR in-house. And there are differences between the entity types. So the deeming entities, some states have their own list of what they require in personnel files. The compliance team has their list of what they require in personnel files. And then Quad ASF would also have their own list of what they require in personnel files. So I try and keep it as streamlined as possible, but my recommendation to you is if you are certified by the state, by the compliance team, or by Quad ASF, whoever your deeming entity is, they typically have a checklist or, and so if you want to reach out to them or to the state office and see if you can get a list of what's required in personnel files, that's a good starting point. But this at least gives you a base of what we find successful for clinics across the board. If you have these elements in place, we have not seen clinics struggle with getting through the personnel file audit portion of a survey. So the first item that we always discuss is making sure that all employees have an application, a resume, or a CV. What happens if you've had an employee for 20, 30 years and this was never a requirement for them? How do you obtain a document and put it into their file? What we typically see here is that you have them submit a current resume and you put that in file, and that should meet the compliance standard. I-9s and W-4s are required tax documents, and we want to ensure that your employees are legal to work at your facility. So that's the intention of the I-9, and that you have them on hand for all of your employees. And then job descriptions, not just job descriptions, but signed job descriptions. This allows the staff member to take ownership of their duties and responsibilities, and you can show that they have received it and then have that job description in their personnel file. And it comes into play a couple of times as we go throughout the rest of these slides. Before I get too much further, Rondi, and do we have any questions so far in the chat box? I meant to pause at the end of the civil rights portion.
No, we don't have any questions.
All right, thank you. So job descriptions become important as you think through performance evaluations, as you think through proficiency testing to make sure that they are able to carry out the duties you've assigned to them. And those are other elements that we're going to discuss as we work through the rest of this HR audit. Another element that should be in each personnel file is assigned standards of conduct. You want to ensure that they are adhering to your vision, your mission, your statement, whatever you have put into place. Code of ethics is another term for this sometimes. A lot of clinics tie this into their personnel orientation packets or your employee handbook, and they sign that they've received that handbook. That is also sufficient. But you need to have proof that your staff have received a standard of conduct and they have signed that they are going to adhere to that standard. Again, another term for that could be code of ethics. And then, as we all know, HIPAA is a big player in the medical field, and so we need to ensure that those that work at our facilities understand the importance of protecting our patient records, and we have a signed confidentiality statement regarding that. Some clinics, they conduct HIPAA training annually anyway. Well, all clinics should be doing HIPAA training annually. And then they're signing that they attended that session, and that usually includes a confidentiality statement on that. That's one way we've seen this met. Some just have a separate confidentiality statement directly printed and signed by each staff member and put into their file. Volunteers is usually the people that we see this missing from. So if you accept volunteers into your facility, especially as events or other items unfold, making sure that they have these same items in their files to show that you have put into place all of the protections necessary for HIPAA. And then performance evaluations. This is based on the job description. Again, going back to that signed job description that they have said they're going to adhere to and that they're capable of carrying out. That performance evaluation should relate back to that job description. These should be completed annually unless your policy states differently. And what I mean by that is some organizations put in a 90-day eval or a 3-month, I guess that would be approximately the same thing. Sometimes they put in a 30-day eval. Whatever your process is, if you've defined it in a policy, that is what you need to meet and ensure is available in their file. One recommended item that I do have, that I want to recommend is that you set up all of your personnel files in the exact same order. And if there's a tool available from your surveying entity, set it up in exactly the same order as what the tool is so that it's just an easy review when the surveyor comes on site. I like to create checklists. That's just me, where I put it in order. I check off each item as each employee file is developed. And then background checks, this is dependent upon your state. I'm not sure if Oregon requires background checks or not. If so, they need to be available and in your survey or in your personnel files. You would want to check with your state to see if that's a required element. And then BLS, basic life support. This needs to be on hand and current for all of your hands-on patient care staff. Some view this as your licensed and certified staff. That's where they draw the line. We just recommend that anyone who has direct patient care, you have current BLS for them. Now, there has been a waiver from the American Heart Association during the public health emergency because they know it's hard to schedule classes to reorient the date of your BLS. However, just double check on that, see if it's still available. If you have providers whose BLS are getting close to expiration or have expired in the last month or so, because we are getting to the point where that may go away soon or it may have already. And so making sure that your staff, if they have direct patient care, you are obtaining the required education for them if needed so that they can keep a consistent and current BLS. Some providers have a higher level than BLS, like PALS or something like that. As long as you have the bare minimum, base minimum, which is BLS, then you are sufficient and in compliance. Just CPR on its own is not sufficient for this specific aspect. I did see something pop up on my screen. Was that a question?
Yes. I'm going to go ahead to Tressa. We have one independent RHC clinic. It is part of our organization, so our HR department manages all HR files. Would you suggest the clinic also keep a personnel file with those documents?
Surveyors, usually the surveyors that I have worked with are completely okay with traveling to see HR files. You will want to have copies of at least licensure on site. That is something that, let's put it this way. Usually the goal is that you want the survey to go as seamless as possible. You want the surveyor to come in, look at your facility, celebrate no deficiencies, and be out in a timely manner, both for the surveyor and for the clinic. And so the more you have on hand and organized, the easier and faster your survey will go. Is it required to be on site? Not that I have been informed of in the state of Oregon. The compliance team, I know they are fine with an outside hospital system to keeping track of that as long as they refer that and show the separation of the hospital from the clinic. Some clinics have outside agencies that they hire to do that. I have not seen it create a deficiency if it's not on site, but again, what is going to make your survey the easiest? If you have organized format, it makes your survey go much faster. I hope I answered that.
Thank you.
Right. Coming back to our HR file, we're going to talk about TB testing. Quite a while ago, it was required that it was annually taken. Again, this just depends on your area. If you are in a high susceptible area, it may be required. But for our purposes, we're going to say it's at least required upon hire, and then if there's an exposure. Then hepatitis B, you do need to have proof that the vaccination has happened or a declination form in your file. Again, a titer draw would also supplement that. Typically what we see with the TB and hepatitis B is that because they're considered medical records, they are sometimes segregated from the rest of the HR files, and that's completely acceptable. The main objective is that you have access to the information if it's requested. Then we go into licensing and certification. So this is for all of your certified and licensed staff, including certified MAs. Anyone who holds licensing or certification, we should have their license type, their name, their title, and then when it expires to make sure that it's still current. So when we're looking at this audit, typically what we do is we list out the name of all employees who are certified or licensed. We put their title next to their name, list out their license number and expiration date. And then if a DEA is applicable to their job type, we would also do that information with the expiration dating. And then for collaborative agreements, it depends on if it's applicable to that job type. I believe, Randy Ann, when we began the session, it was in Oregon, NPs are able to act at full scope and be independent, but PAs do require supervising physicians. So just ensuring that you have appropriate collaborative agreements for those mid-level providers that require it, and then having the appropriate supervising physician title in place as well, and that you have a document to show that this has been taken care of. There are two types of chart audits, so a little bit different than the HR audit. There are two types of chart audits that you have to define in your policies. One is administrative, and that is where you're checking the elements, being sure that the chief complaint is present, that the provider signed off on the chart, and there's just a list of elements that have to take place. And then there's the collaborative chart review. So the administrative review, the requirement there is 50% or 50 charts or 5%, whichever is lower or higher. I apologize. 50% or 5%. Oh my word, I can't talk today. 50 charts or 5% is what you have to review for the clinic, the administrative piece. That's where we're checking elements. The collaborative, you choose the number of charts unless your state has a specific number required to that license type, and you put that in your policy, and that's what you're held to. You define the number and the frequency that that is happening. Okay. Training. There is a whole list of trainings that have to be completed on an annual basis. I have a list of some of them here, such as your tobacco policy, non-discrimination policy, like we mentioned earlier, your OSHA training, and your HIPAA, and then, of course, your fraud, waste, and abuse. And making sure that you have proof that these trainings are taking place for all of your staff. Then we're looking at proficiency testing. So we're going back to that job description, and I'm talking not just your providers and your nurses, but also your reception staff. listing out what their duties are and confirming that we have shown they're proficient in those areas, and having proof of that documentation in their file. Sometimes that's pulled into the performance evaluation, however you want to set that up, as long as you can show you know and you've documented that your staff are proficient to carry out their duties. Proficiency testing is different than competency testing. Proficiency testing is based on the job type. Competency testing is specific to labs, or if you're implementing a new service like injections or something like that. And that's where you have a provider, so an MDDO or whoever you have designated is looking to see if your staff are competent to carry out those tasks. And then there's 4 forms of monitoring that process. And then OIG, Office of Inspector General. And I'm putting the link here for you to have, again, making sure that the .gov is your go-to resource for that. And I wanted to give you an example of what this is. The OIG exclusion search is required upon hire and annually. Some clinics tie this into credentialing, background checks. However you define it, as long as you can segregate and show that you do not have sanctions against you where you can't work in the facility, that's the intention of this document. Simple form is you go to this website, you enter in each of your staff members' names, and you print that they are not on the exclusion list. And that should be done on an annual basis. So how does that work? What does that look like? This is what you see when you go to the website, and there's a space where you can list out the last name and the first name of your staff member, and then you push search, and I searched my name. Apparently I'm able to work at your clinic because I'm not on the sanction list. What happens though if their name pops up? Sometimes you have a common name and there's more than one person who has that name, and they pop up on this search, but it's not necessarily the person who's at your clinic. And so you would go in and you would enter identifying information that's more advanced, such as your social security number or driver's license number. And there's a way to do an advanced search to clear that person to work at your facility. Whatever information you use to clear their name, you want to make a copy of that and attach it to the OIG exclusion list that was found. So before we move into emergency preparedness, I want to ask if there are any specific questions relating to HR or to civil rights.
So are the civil rights and RHC requirement, or is that a requirement from a different entity?
It's not necessarily outlined in the RHC guidelines. It is a requirement from the Office of Civil Rights that all healthcare providers adhere to civil rights requirements. And so as a provider type, you are required to do that, not necessarily because you're an RHC.
Okay, so and I have a question. So is it a requirement that the surveyor enforces that?
No.
Okay, okay.
No. Usually what we see is you have to do the assurance of compliance through the portal in order to even be certified. So that's part of the process as well, that you're attesting that this is in place. And then if you were ever to be audited by CMS or by the Office of Civil Rights, and they ask for proof that you have policies or you have this information available, that's where it usually comes into play. I don't really see surveyors actually look at this information.
Okay, and then you only submit the assurance of compliance once?
I believe so. I would have to ask my colleague Michelle on that because she's the person that takes care of that for our team.
Thank you.
Mm-hmm. Some states, not Oregon, some states actually require you to upload your civil rights policies before you can be surveyed. I do not believe Oregon is one of those states. I know Alabama would be one, and I believe Kentucky or Ohio is also one. Did that answer the question, or was there additional follow-up to that?
Yes, that answers the question.
Okay.
I had additional questions, so I think that answered it. Thank you.
No problem. So again, majority of the time when you're actually in survey, I don't see the surveyors looking for this information. It is just something you need to have in place in case there's an additional audit from an outside agency. Okay? So now we get to dive into the fun of emergency preparedness. And this part of the session really takes on the idea that you already have a plan. I will go through the components as much as possible, but it's coming from a perspective of, okay, now it's time to review the plan you've already developed. So if you have questions regarding the compliance piece, please reach out. I'm more than willing to help with that. But this takes the assumption that you already have a plan in place. So there are 4 components to the emergency preparedness plan, and they are risk assessment, your communication plan, the policies that are outlined in the regulation, and then the training and testing program at your facility. Towards the end of our presentation, there are some slides that we will go through that show the update that has come out in this past year, regarding how to develop your testing program and what's considered an exemption. So what is a risk assessment? A risk assessment is an evaluation of vulnerability to specific hazards. Hazards need to be categorized by the same standard to qualify for a risk assessment. And it also helps create a numeric value for each risk so that you're evaluating everything from the exact same standard. And then a living document that should be updated at least biannually. In September of 2019, the burden relief document final rule came out that allowed a clinic to move to a biennial process. Instead of having to do a review annually, you can review your emergency plan, your policies, and your program evaluation every 2 years. And so that's what we're taking into consideration here, is that you're reviewing this and you're doing a new risk assessment at least biannually. Recommendation for your current plan that you have is that you list out the address of the facility that you're doing the risk assessment for, because we want to make sure it's specific to that specific geographical location. So list out the name of the facility, the address, and then the year that the assessment was done. That way you can show you're keeping that biannual process in place. So how do we conduct a risk assessment and how do we update our current risk assessment? First recommendation is that you do some research. You look at your state and county mitigation plans, because majority of state offices and the counties already have mitigation plans put together, and they've done a lot of research also on what your current natural hazards really are. What's a high risk in your geographical area. So look at those resources because they're already there for you. And then if you're part of a network or a hospital system, look and see what your hospital has determined as top risks. If you have access to an emergency manager, that's even better. Have them come out and help you conduct that risk assessment. And then look at it from a local perspective, so your clinic. What actual events have we experienced at our facility? And it needs to be both internal and an external risk assessment. What in our community or in our area could pose a potential risk to us? And so we need to look at these risks through 3 lenses. What's the probability of this risk happening? What is the impact if this event does happen? And what response is available through our facility and through local resources? How prepared are we to answer this risk? So those are the 3 lenses you want to look at each risk with, but it needs to be an all hazards approach. What does that mean? Well, you need to assess the risks through 5 lenses. Naturally occurring events such as severe weather, hurricanes, winter weather, if that's applicable to your area. Sometimes wildfires is a big concern. What are the naturally occurring events in your area? Again, referencing back to that item that is covered in the mitigation and county plans. So naturally occurring events, technological events. So are you prone to power outages or communication failures? Does your EMR go down every couple of weeks? Is that a high risk for your facility where you're not able to carry out patient care on a consistent basis? Human related. Are you in a high crime area? Are you susceptible to active shooters or volatile patients? If you are, you need to address that and make sure that you have a risk or a policy to address how you would handle that. And review all of these risks through that same lens. Make sure you're giving it mathematical equations. And then hazardous materials. Is there a potential that there could be a hazardous spill Or a chemical spill? Do you have chemical or nuclear plants nearby that could cause an explosion? That could be a huge risk for your facility. And then the last one was added in February of 2019, and I find that it's very prevalent for today. And that is infectious diseases, not just COVID-19, but overall, we have to address infectious diseases as we're developing our risk assessment. There are some great tools out there that you can use that already are invented. There's no need to reinvent the wheel. Kaiser Permanente is one source that we use on a continual basis, and it lists out all of these hazards and then gives space for you to consider those 3 areas that we already covered: the probability, impact, and response. And then they do the work for you to determine the mathematical equation on how high of a risk is this for your facility. I believe I saw something pop up on the side regarding a question.
Yes, in the Q&A from Sean Cosby, if the has vulnerability assessment was done by a third party, does it need to be reviewed biannually, or does a new assessment have to be done?
You need to do a new assessment. That's okay. You need to do a new hazard vulnerability assessment each year, or sorry, every 2 years. So you can look at it and see if it's still applicable to your site, but you do need to sit down and actually go through that risk assessment at least every 2 years. Use the same documents, but you should at least confirm our risks have not changed, or if risks have changed, say there's new construction in your area that could pose a risk, or you've experienced actual events that you've never considered before that you need to address now and have heightened your risk awareness. Maybe COVID-19 has heightened your awareness of the risk of emerging diseases in your area. Whatever has changed in the last 2 years, you need to address through a new risk assessment tool. Thank you. If your risks do not change, then go back to that document, again, making sure you have your facility information there to define this is for this facility, and then update the year that that assessment was done. But you at least have to show you reviewed it and you're confirming no changes to your risks. So a risk assessment must complete it at least biannually. Some items to consider as you update your risk assessment, like we just covered: actual events that you've experienced, new construction, news reports. Sometimes health departments also provide memos or information regarding upcoming risks or outbreaks that have taken place. So take that into consideration, sit down and go through that tool that you've used to previously define your risks and see if there's any adjustments that need to take place. Each location must have an individual risk assessment. There's going to be a big question you have to ask yourself. Is my plan, can I enact my plan within my 4 walls? So if you have a risk assessment for a hospital that's 40 miles, 50 miles, 60 miles away, even 20 miles away, your risks may be very different. So we can't have everything fall under one risk assessment. Each facility has to have their own risk assessment. Communication plan. There are 2 sides to this coin. We need to have an internal communication plan and an external communication plan. So your internal communication plan, you want to make sure you have contact information for all of your staff. If you allow for volunteers, your physicians, any arrangements outside facility or outside specialists or facilities, making sure you have contacts there. And then a list of receiving facilities on where your patients can go to receive care if you have to close for a time. And this is one of those documents that seems to be ever changing. Staff turnover is an item with that. Making sure that this internal communication plan is kept up to date. And then defining how you enact your communication plan. What is your call down time? What is your call down process? Who's responsible and who's the hierarchy of command? And do your staff know who they're supposed to contact? And is that defined in your communication plan? So not just having phone numbers, but defining the process of who's responsible for contacting. And then your external communication plan, you at least have to list those that are listed here: your federal, your state, your tribal, your regional, and your local contacts. Always make sure you include 911, of course, but you also want to list your local police, your local fire, any resources you have in your area. Some clinics have access to a rescue squad in their specific area, making sure you have that contact information listed on this document. And then you move into your regional or your county. And so you're listing out your sheriff and your emergency manager for your county. And you're listing out all of your local resources, your county resources. If you have access to tribal resources, making sure that those are included as well and not neglected. And then your state information as well. So at least your information regarding your emergency manager for your state. If you have a coalition, include that as well. Each state is set up differently on what resources they have available. So look at your state website and include any information that could help you in an emergency and include them on this contact list. And then of course, the federal FEMA has regions, and making sure that you have their contact listed on your external contact list as well. Then we go into our vendor list. So this is part of that external contact list. And really the intention of the vendor list is that you have access, and easy access, to contacting persons or entities that might be coming to your facility to tell them it's not safe to do so, or to tell them you need additional supplies. An example of that is if you had a vendor list or a supplier who provided PPE to you, you probably had to contact them to obtain more during the public health emergency we're currently in. And so you want to have a vendor list of your suppliers. We also recommend including your utilities on this list of who can assist you in the midst of an emergency. And then we need to have a communication plan, a defined process of how you disclose information on the condition of patients, depending on the type of event you're in. Who's responsible for that, and how do we still maintain HIPAA if there's no waiver in place? And then how do you define your communication for obtaining needs, if you have needs, and the resources you can offer during an emergency, and have all of this outlined in your communication plan. So how do we update that? Because again, we're focusing on the review portion. Take into consideration staff turnover and keep those internal documents updated. Make sure that those who have roles and responsibilities in the midst of event know what their roles and responsibilities are, and that's communicated to them fully. Update that call tree. And if you have multiple locations, make sure you have a communication process between your locations. An example of this is I had a clinic who had building A is what we'll call it, and that was 5 minutes from building B. They had a patient that showed up to building A looking for medication refill of a pain medication. Building A said, I'm sorry, we can't do that. You're beyond your process. And so patient showed up to building B, very irate and hostile, and it escalated very quickly. Building A never called building B, where building B could have gone into lockdown or at least been on high alert for that. So making sure you have a process in place and you've defined that in your communication plan. And then listing out any communication tools that you have, such as cell phones, walkie-talkies, ham radios, anything that you are able to use for two-way communication throughout the course of an event. You want to have a list of those tools available in your communication plan. As you think through your external list, update external communication plan. What happens if there were governmental elections? I mean, we're going through that right now. Maybe there was a different contact than who you had previously listed. And then previously you had to document all contact out to obtain assistance or to participate in additional trainings. Burden relief kind of did away with that requirement. They're trying to allow clinics not to have to do as much documentation. But still making sure you have your trail if needed. And then again, if you've adapted new communication tools, putting that into your documents and updating your vendor list if you've had to diversify your suppliers like most clinics have during this public health emergency. Before we move into policies, are there any questions on the risk assessment or the communication plan so far?
No, there are no questions at this time.
Thank you. All right, policies. Some of these are directly listed in the regulation and some are just good practice, and I will try and differentiate that for you. Evacuation, this is one that's required. You have to define your evacuation process and your meeting point. Where do you meet outside of your facility if you have to evacuate your clinic? So have that listed in a policy. And then how do you handle sheltering in place, whether that is due to severe weather, outside occurrences, active shooter, that's usually more lockdown, but how do you handle sheltering and what is your process? We are not hospitals. We do not have to show 72 hours, I think it is, of water and food. We're not an inpatient facility. We are outpatient as RHCs. And so you don't have to have all of that detail in there. What you do have to show is, here's our meeting point for sheltering in place, and here's what we would do if, like shutting down your ventilation system or your air filtration system, if there's an outside exposure where you have to shelter in space and it's not safe to have your windows and other items open. So that's your shelter in place policy. Again, meeting point for your evacuation and your shelter in place, and staff should be aware of where those meeting points are. Then your medical documentation. How do you handle medical documentation throughout the midst of an event? Who's responsible for handling documents or securing documents? Say, for instance, you have a power outage and you have to move to your downtime forms for a time. Who's responsible for securing that information until it can be uploaded back into your EMR? How do you transfer patients in the midst of an event? And do you have access to your files outside of your clinic if your clinic is not accessible? Some clinics who are part of a network, this is much easier for them to obtain. But independent clinics, this can be a struggle. How do you access your files, especially if you're paper only, but how do you access your files and prevent files from being destroyed in the midst of an event? Making sure you have a plan in place and documenting that in a policy. And how do you handle volunteers? A lot of times we just see clinics put the statement in, we do not accept volunteers at our facility. If local authorities enter our facility, we allow them to act within their authority, or however you want to define that. If you do have a volunteer process, making sure you define that in your policy and that they adhere to the same training requirements as your other staff so that they know what their role is and what their allowance is, and that they're still going to protect PHI in the midst of an event. And then medication handling. This is not specifically listed out in the regulations, but a lot of the clinics that I've worked with, they have had to have this in place. One, because specifically the compliance team does require that you put the medication handling directly in your emergency plan. Some states do, some states don't. I do not know specifically the standard for Oregon, but it's a good recommendation. You put your power outage procedure for how you handle medications directly in your emergency plan. You should have a policy for this already, how you handle your meds, how you monitor your temperatures at your clinic, what happens if there's a recall. All of that should already be in a policy. But then in your emergency plan, you're listing how you handle an event. So if there's a power outage, where are your medications going to be transported to? Do you have the correct equipment on hand to transport medications? And how are you mitigating the gaps and monitoring that process? Have that defined and put it in your emergency plan. And then we have situational policies for those risks that we've determined. So we do our risk assessment, we pull out our top risks, and then you need to have a policy for how you're going to address each of those risks. So policy updates. As you look at your review process, you've had your policies in place for at least 2 years, so now you're going to go back and you're going to review your emergency plan. Have your meeting points changed? Maybe that dumpster you used to meet by is no longer in that location, so you need to redefine your meeting point. Or maybe the parking lot across the road that you used to meet at is no longer there, it's been torn up and a building is there. Making sure your meeting points are still current and your staff are aware of what those are. So updating those if they need to be. Updating your risk assessment might allow or might require you to also update your situational hazard policies. So if you've determined other risks are now higher, you might have to address those risks, new risks with a policy, or you do need to address those new risks with a policy. And then of course, as you create after action reports on your events that you experience, there could be updates to your plan or your policies based on your analysis of your how the events go. So I'm going to pause there regarding policies. Any questions on policies?
No, I'm not seeing any questions.
One item I would recommend as well, it's not included in this list of policies, is I would also recommend having a policy in your emergency plan regarding how you handle lockdown. And I would recommend adding a policy regarding how you handle an outbreak or infectious diseases, especially in light of COVID. But again, in February of 2019, Appendix D was updated to require you to at least consider emerging diseases and have a policy regarding that. So adding language on how you handle a contagious patient, including that right in your emergency plan. So now we go into the fourth category, which is the training and testing program. And those are two separate things. Training is specific to your staff, and this is required at least biannually. I recommend annual training because, again, there's so many nuances that change on a consistent basis with this. So the training is specific to your staff, and then testing is ensuring that you are able to enact the actual plan, and you test that through hazard exercises and drills. Training itself, all staff have to be trained on their expected roles. Staff need to be trained upon hire, and again, at least biannually. The recommendation is annually. And then include volunteers or other individuals that may act within your clinic during an emergency event, making sure that they are understanding of what their process and role is as well. Typically, what we see followed during a training event, we usually use a PowerPoint process, and it's the easiest that I have found, and we outline the risks that are defined at the clinic, how we came to those risks. We also go through who's responsible, the hierarchy and the delegations of authority, the succession plan, if that's that should be defined as well. And then going through the roles through each event that we've determined as risks, going over those meeting points, where the plan is in the clinic and how to access that plan, and how to navigate the table of contents to go back and know what we've defined as our response. I see a question, or is that just the webinar survey?
That's just the survey.
Okay, thank you. So now we go into testing, and this piece here is a little bit of a, can get a little hairy. So stick with me. There's a document that I'm sending to Rhonda Ann as a handout, and it will define it in much better detail. So disclaimer, always check with your deeming entity. So if you're surveyed by the state, always check with them to see how they're interpreting this new guidance. And then read the full document. I provided the link here, but I'm also going to send Rhonda Ann the document for your review as well. So where did we begin? Back in November of 2016, the emergency preparedness document was finalized, and then everyone had to implement it by November of 2017. At the time of initial release, the testing program at the RHC had to include one required exercise and one exercise of choice every single year. So again, 2 trainings per year, 1 required, 1 exercise of choice. This is still your requirement if you have not updated your policy to adhere to that biennial process that was given during the burden relief. Then in September of 2019, CMS issued the final rule that allowed an RHC to move to a biennial process for the emergency plan review, program evaluation, and policy review. RHCs are able to adopt this process as long as you update your policy. So what did the burden relief do? It moved it into a testing cycle. You only have to do 1 training per year instead of 2. The 2 trainings are biennial now. The first year in the cycle is required exercise, and the second year in a cycle is an exercise of choice. At that time, what we believed, or what we've seen happen through surveys, was that an actual event would exempt you from having to do any additional exercises that year. Current guidance. So September of 2020, CMS issued updated guidance for how to enact the exemption. So if you had an actual event, you were exempt from doing any other testing of your plan. CMS now issued an updated guidance for how to enact your exemption and what qualifies as an exemption. And this is only when a clinic experiences an actual event and the difference between a required exercise and an exercise. So at this time, I feel it's very important to tell you the law didn't change. When burden relief came out, it changed to reflect biennial. But when this update came out in September of this last year, the law did not change. How we interpret that law is what was provided. We were given additional guidance. So the law currently states in the CFR 491.12 that if the RHC experiences an actual event or man-made emergency that requires activation of your plan, the RHC is exempt from engaging in its next required full-scale community-based or individual facility-based exercise following the onset of the emergency event. I added the highlight and the bold and the underlined to the key words here, but the law did not change. So current guidance, there's a difference between required exercise and an exercise of choice. Required exercise, so that's the one you have to do in the first year of your testing cycle. Required exercise is a full-scale exercise or a functional exercise. Commonly, this is also referred to as a community-based, community scale exercise, where you incorporate more players than just your clinic. Hospitals are very familiar with these as well, and a lot of coalitions allow clinics to participate. And so that's what's defined as a required exercise. And if you go back to that document that I'm going to give to Rhonda Ann as a handout, the QSO 4021 all, that one defines these in more detail of what qualifies each of these exercises. So required exercise is full scale or functional. Exercise of choice is on the second year of that testing cycle, and that's a mock disaster, a tabletop drill, that's usually what we're familiar with, and then a workshop. You can also do a secondary full-scale or clinic-based exercise. So now we get into the exemption clause, and this is really the intention of the document that was released in September, was to define what an exemption is and what qualifies. An actual event exempts the clinic from that next due required exercise. It does not exempt the clinic from the next due exercise of choice. So here's the visual that came in that document, and I apologize, it's a little bit blurry because I had to expand it. An example here is if your clinic did a full-scale exercise, so that required exercise in January of 2020, you experienced the pandemic in March, you had an exercise of choice scheduled for this coming January or this month, you would still have to do that exercise of choice. But then January of next year, when you were required to do that required exercise, you would be exempt from having to do that exercise. So put that on the flip side. What happens if January this year, you did an exercise of choice, because that's where you were in your testing cycle. March, you had that activation of your plan, so it's an actual event. So January of this year, you're required to do a full-scale exercise, but now you can claim an exemption because you had that actual event. And you wouldn't be required to do another training until next January when you do your exercise. This gets a little hairy, like I said, and there's a lot of questions that usually come from this piece. But I wanted to make sure we got through the information. And again, I'm giving a handout that puts this in much more detail, and you're able to go through and read that. So what are the action steps? What do I do as an RHC? How do I know if I'm in compliance? Define your testing cycle, put it into a document, put it into a table, and then figure out what was even due this year before COVID hit. Was I needing to do a required exercise, or was I on the schedule to do an exercise of choice? Figure out where you were in your testing cycle to know if you still are needing to do additional testings. Here's an example of how to track that. And so you list out the type of exercise, and you list it as either required exercise or an exercise of choice, what type of exercise you conducted, and then when it was completed or when it was due, and if you have an after action report completed. This is typically how we see clinics be successful in tracking where they're at in their testing cycle and to know when their next exercise is. For this example, in June of 18, they did a required exercise by doing a community-based flu clinic. In June of 2019, they did an exercise of choice by hosting a tabletop drill. Then March of 2020, they did an actual event because of the pandemic, and they reported on that. So they would have been due in June of 2020 for a required exercise, but they were exempt because of that actual event they experienced. So their next due exercise is in June of 21, when they're going to do another exercise of choice, which here they have listed as a bomb threat tabletop. So what are my action steps as a clinic? Understand the exemption clause and be able to define to the surveyor or to your organization how you enacted your exemption, and make sure you have documentation that shows you were able to enact your plan. Document evidence that you enacted your emergency plan, and then so that you can determine if you were testing your emergency plan in the first place. And this is normally shown through an after action report. There are some great examples of after action reports. The main objective of an AAR is to analyze your response and then have a plan of correction as needed as to your response, and then update policies based on the outcome of your analysis through that report. CMS has a great example. There's no point to reinvent the wheel. They have a great example of an after action report, and it comes with instructions. I figured if CMS is the ones that are certifying us and they give us a document, probably best to use their information. So normally what we do for an after action report, there are 5 components of a successful after action report. You list out what capabilities you tested. You list out your timeline of events. Then you at least list out 3 strengths, then 3 areas of improvement. And for each area of weakness or areas of improvement, you should have a recommendation or a plan of correction on how to address those weaknesses, and then sum everything up with a conclusion statement on whether the event was successful or not for your clinic. So what do I do with all this information? We covered the whole gauntlet of emergency preparedness. What do I do with all of this? Bring all of your updates when you complete your review of your risk assessment, your communication plan, your policies, and your training and testing program. Bring all of the updates and documentation from that. Bring it to your program evaluation meeting and get it approved, and then send all of your updates to staff for training. That is, in a nutshell, critical maintenance on civil rights, HR audits, and emergency preparedness. I have some time here for questions if you have any, and then I also want to give you my email address if you'd like to reach out directly, or we can go through Rhonda Ann as well, whatever is most convenient for you. Any questions?
I do not see any questions. I do have a question though. Does HSA offer the completion of emergency preparedness plans for clinics?
Yes, that is something we do. I've developed many emergency plans across the nation, and they've passed survey with all of the deeming entities and states so far.
And what do you charge for that? Is there a certain fee that you have, or?
I would be able to connect you with Chris. I don't do the contracts or the financial piece of that for our company. I'm the one that actually develops the emergency plan, but all contracts go with Chris Christopherson, who is our CEO. But I can connect you with her if that would be helpful.
Okay. Well, those are my questions. So thank you, Tressa, for this presentation today. It was packed full of information, and you are a great educator, so we really appreciate it. We hope we can bring you back again soon. As a reminder, I put a link in the survey, to the survey in the chat box. Please just take a minute to complete the survey. The Oregon Office of Rural Health will also host a webinar on January 21st titled RHC, What Now After COVID-19 with Kate Hill from the compliance team. And beginning January 28th, Lauren Harris, a practice management consultant here in Oregon, will offer a leadership development series with 5 workshops. The series will be packed full of ideas to expand your leadership knowledge. So I appreciate you all staying on a little bit longer. Thank you for attending, and have a good afternoon. Again, thank you, Tressa.
Thank you.